Hello, and welcome to The Two View, the cutting edge educational and interactive show for PAs and nurse practitioners in emergency medicine and urgent care. I'm nurse practitioner Martha Roberts, and I'm here with a very good friend for a very special podcast. Hello to my co host, Michael Sharma.
Hello, Martha. It's great to be back with you again. And hello to you, listener. Quick shout out to you for joining us for the first time, especially if we met at the Texas Academy of PAs conference last week. I got to deliver some talks, meet some fellow PAs from Texas and around the country, and both were equally a great honor. Welcome to the podcast.
This is going to be a very sad and formal announcement. As some of you may know, we lost a titan in emergency medicine recently. This person was my father, James Roberts.
Dr. Roberts, or Jim, as he went by for most people, may have been the most frequent guest on the Two View. Listener, you would have heard him as recently as our July episode 18. It's a big blow to the Two View community. Personally, I lost my father a few years ago, and so I can appreciate personally what you're going through right now, Martha, and we're also very sorry for your loss.
Thank you, Mike. You have been extremely helpful for the last couple of months, and I put off doing this podcast with you. As you know, I wasn't just being lazy. It's been really hard to kind of jump back in the saddle, and I really do appreciate you and Rick covering last month. I missed a couple of boot camps, and I'm happy to be back. I'm able to sort of move a little bit forward, not necessarily move on. But I'd like to say a few words about Jim, if that's okay, Mike.
Yeah, fire away, Martha.
And then after that, I'd really like to read from two of his most popular and influential pieces of writing from Emergency Medicine News, his In Focus column, where he was the chairman of the magazine for almost 40 years. Jim and I worked very closely together on a blog for almost a decade called The Procedural Pause. And all the videos of emergency medicine procedures, we tried to focus as many as we could and get them on there over the years. They're all still there for you to watch and read if you want to. So thank you again, everyone, for tuning in for this particular special episode of The Two View. Jim Roberts, he was definitely one of a kind, and I know touched the hearts and minds of many of you. As many of you know, Jim was one of the first ER and toxicology doctors in the country and was an original faculty member for CCME. He helped define the specialty with his candor, creativity, zest, and passion for the patient, and most importantly, his caring and positive attitude. A trailblazer, medical expert, insightful toxicologist and doctor with a soothing bedside manner, and cracks some really good jokes once in a while. Over his 50 years in healthcare, Jim paved the way for the first batch of residents. He wrote and published numerous studies, articles, books, review guides, and pamphlets that people are still using, in fact, might be using right now as I speak. And he wrote board review lectures, gave thoughtful live talks, joined podcasts and professional meetings. He professed his love for emergency medicine. He was a well-spoken professor and lecturer and traveled the world spreading his teachings. Like a domino effect, patients and healthcare workers have benefited directly from his work. A few other accolades from a list of many. Jim was the lead editor, as I mentioned, for Emergency Medicine News. He wrote his column, I'd like to say, once every month, but he spent hours, sometimes days, writing those columns. In his early years, I sat under his desk drawing on paper anatomical pictures of hearts and brains, hoping that his knowledge would fall down upon me under his feet. He typed away on his typewriter and mumbled words I didn't know at the time, but they were interesting and addicting. I was inspired every day by Jim. I was so lucky. I saw a part of emergency medicine that no one else got to see, and I learned things I am forever grateful for. I grew up watching him lecture for our courses in incredible places all over the country with my other dad, Rick Bucata, who has known me since I've been a fetus. And I sat in awe watching my other hero, Diane Birnbauer, grace the stage, having drinks and laughs in the Keys, Vegas, Vale with Greg Henry, Ken Milne, Jerry Hoffman, Mel Herbert, Amal Mattu. So many of you I am privileged to know. And now in my 40 years of life, I get to call all of you my dearest friends, my colleagues, and my extended family. Jim just wasn't a teacher and a doctor. He was my best friend and my mentor. We worked together on multiple projects, and some of the best days of my life were lecturing with him on stage. We are now in the 8th edition of his book, Roberts and Hedges, Clinical Procedures in Emergency Medicine and Acute Care. And with a brilliant team of editors, we hope to finish the book for him. I can remember some of the shifts that he took all the photos that are still in the book today. Jim was also a great patient because he let me suture on him, inject him, and relocate a few of his bones. Many of our procedural videos featured a few of his ailments, which he kindly shared with our community, showing the real side of the patient, and he so eloquently taught while having the procedure done to him. Let's just say that I did excuse myself one time, though, when he needed a catheter after surgery. I think that's when I had a hard stop. I have so many hours of videos and procedures that we worked on, but when we weren't working on work or a podcast or a talk or a publication, we would do what we called work for fun. I know, sounds boring to some, but we got a thrill out of mastering techniques and tricks of the trade. Like many of you, we wanted to be better, better at our craft, better at everything we did, and we always loved learning. Some nights, Jim and I would sit mapping out the clotting cascade, playing with ABG numbers, reviewing anatomy, just talking about procedures we wanted to tackle next. We wanted to alert anyone and everyone about the best way, the safest way, and the most respectful way to perform these tasks on our patients. EM was a calling and a vocation to us, and we had a very special bond, traveling, teaching, learning, and exploring. I was Jim's first scribe when I was 14, and he used to throw a white coat on me so I could go into the rooms and take histories. In the past few years, I'd call him after a shift, telling him about something I'd seen, and he'd remind me not to forget the important stuff. We reviewed the zebras of medicine, and he reminded me to give that patient a call back the next day just to see how they were doing. But Jim was also a dad, a brother, an uncle, a husband, a grandfather, and a friend. He was witty, modest, kind, and he had a really wacky sense of humor. He was an incredible fisherman, great storyteller, and adventurer, and we camped and discovered fun things to do. We spent time with family, we made memories. We cooked together, shared drinks, stories about life, love, and our sadness, both in our personal lives and about the things that we saw in the ER. I wish that I had time to share with you all of those stories. We faced challenges together. He was my rock, and he was my phone a friend. I would be nothing and no one without my father, not just in the world of EM, but in my personal life. I'm not really sure what I'm going to do without him now, but hopefully I can lean on some of you as our challenges grow in healthcare. And maybe I can run a cool case by some of you now and again. As Jim would say, the keys to life and medicine are exactly the same. Always be kind and considerate, laugh when appropriate, be gentle and humble, be on time and don't ruffle too many feathers. Always check a glucose, couldn't hurt. Know where a crash cart is or some emergency device. Take time to talk to your loved ones, your patients. Stay level headed, never go to bed angry, and be grateful that you have a close friend or family member you can always call in the time of need. We need each other in this life. Jim was a great many things, but most importantly, Jim was fun loving. He loved what he did and he was good at it. He was an intelligent man who knew a lot about life, a lot about emergency medicine, and a lot about people. Jim was remarkable, and we're all going to miss him.
Martha, thanks. It was a real privilege for us to hear you speak from the heart about a man you knew so well. It's been said before, never meet your heroes because they don't usually live up to your expectations. And that's happened to me before in other avenues. Jim was a hero to so many, and I have no doubt to the many that he met that saw him as a hero, like how I saw him, that he exceeded his expectations like he did for me. A few weeks ago, you mentioned Amal Mattu shared a talk on his own podcast from Jim as a tribute. It was a talk that Jim gave in 1995. And Dr. Mattu says he still listens to it on audio cassette. Google that, listener, if you're not familiar with what an audio cassette is. But every couple of years, he would listen to this talk. And can you believe it? Think about if you told Jim that night, like in 1995, Jim, people are going to listen to this talk, this exact talk. People will listen to it 30 years later. And I can't imagine he would have believed you, When you told me that your dad had passed away, and then later I was listening to this talk of his a few days later and admiring that Yep, it was like still funny and educational and relevant in 2022. And I was just so sad. I had this image in my mind of this light going out in the house of emergency medicine. But then I realized that the light had not gone out. It had been spread to thousands upon thousands of people who all now carried this light with them. And if anything, the light was now even brighter, and it continues to spread to this day. There will be a link in the show notes to that talk of Jim's, just like you do for everything else on this show. The show notes can be found at twoview.fireside.fm. That's the number twoview.fireside.fm. Like you said, Martha, we're now going to read from two columns that Jim wrote for EM News. I read them even before, Jim got sick over the years and thought they were wonderful. The one column is a real time capsule of where our specialty has come from. And the second column is a great guide on what comes next if you've chosen to join this specialty of emergency medicine. It is a real honor to read with you these words from Dr. Jim Roberts.
And a side note, if you're going to be at ASAP this year in San Francisco, where I will be hanging out with some good old friends and going to the parties and listening to some great talks, you can head on over to the Hilton Franciscan slash AB room. That's how it's written on it at 5 p.m. on Sunday, October 2nd for a memorial and a gathering. There'll be food and drinks and a great slideshow and a few surprises and a couple nice guests saying some kind words about Jim. So we'd love to see you. That's Sunday, October 2nd at the Hilton at the Franciscan AB at 5 p.m. So, Mike, I'm going to start with this first column that actually had been published a time or two in Emergency Medicine News and some other venues as well, but was finally updated just about a month or two before Jim got sick. And it was really, it was, I think it got published possibly a
This
week.
says June. Yeah, so it's
Yeah.
like so recently.
Yeah. It's not like Jim knew he was dying or he was sick. It was actually quite shocking. He died from a massive stroke. It was unexpected, and he had been on the podcast just that month before, so working and doing his normal thing. So the fact that this was there, I'm glad that it got in there because it really says a lot about his time in emergency medicine. This is called Looking Back on a Career in Emergency Medicine. I retired from full-time clinical emergency medicine not long ago, and it made me think about what an amazing specialty it is and how it has evolved over 50 some years. Emergency medicine didn't really exist when I was an intern trying to decide my future. It was something that you did while waiting for your real career to begin. The ER, it wasn't called the ED then, was staffed by interns and a few begrudging attendings from other fields who viewed it as punishment that had to be occasionally endured. Odd as it seems now, the most difficult field was handled by the least educated clinicians, and it was crazy to think that I could ever be a lifelong calling for me. I tried to put my career into perspective over the years with my acknowledgement of some of those spectacular clinicians who founded that developed this and developed the specialty. And it was interesting to contemplate my journey through the most amazing specialty in modern day medicine. Thanks, everyone, for an amazing 45-year career, one that began at a time when I knew every residency trained emergency physician in the world personally, all 5 of them. These are notes from my first 25 years in emergency medicine.
1972. I spoke to my medical school advisor today. He said, "You want to do what? Work full time in the ER? You got to be nuts." He seemed like a smart guy and was probably right by prognosticating that there's no future in the ER, but it is pretty exciting. Funny thing though, nobody really knows what they're doing in the ER. Lots of weird stuff. Adrenaline junkies work there. No real help from those consultants who offer us a lot of second guessing and criticism. There's not even board certification in that specialty. Guess I'll go into OBGYN. That'll make my mother happy.
1973. I'm an intern at Highland General Hospital in Oakland, California. OBGYN sucks. Those Pitocin drips are the worst, and all you see are women who scream a lot. I can do a month in the ER if I want. I'll give it a try. Maybe I can find my calling there, or at least decipher what internal medicine field I might fit in. But I kind of like this ER stuff. I heard about a doc named Bob Daly who does it full time. We'll give him a call and we'll sign up for another month in the ER.
1974. Internship finished. Love Berkeley, but too many Quaaludes. You get them free from the pharmacy, and it's legal to grow pot here, but that'll never catch on. We'll miss the Fillmore, Haight Ashbury, sporting my ponytail, and all those cool California women and places. But time to think about a real job. Not. Instead, I am going to Turkey. Got a VW bus and drove to India. Did not like Pakistan. Afghanistan did not like us. Maybe it was my ponytail.
1975. Got a job in a local ER. Cool. But I don't know squat. Heard about this pseudo residency at Medical College of Pennsylvania in emergency medicine. MCP used to be called Women's Medical College, but it went bankrupt. Maybe that's where emergency medicine is headed, but I will check it out. They don't even need me to fill out a formal application. Just show up on July 1st. This emergency medicine stuff is a lot different from internal medicine. Met a doc named Dave Wagner and this guy, George Schwartz, pretty smart guys. They think full-time ER just might work. Think I will do that residency. My mother wants to know when I will be a real doctor. She really wants to see my office. I started EM residency in July. Might be a mistake, but we'll give it a try. Best part is that you can wear scrubs to work every day, no tie. Gotta love that.
A patient stopped breathing, so I intubated him, just like I saw them do on my anesthesia rotation. It's not that hard. Just put the tube in a little hole with those two white cords at the beginning. The head of anesthesia was furious and complained to Dr. Wagner. She said she would personally testify against me in court if I ever intubated again. That was a job of anesthesia. I should call the nurse anesthetist. Dr. Wagner just laughed and told me to keep up the good work. I've got to be insane to put up with this garbage. Glad I can commiserate with a few other crazies out there. The head of medicine said I was crazy. Why don't you quit this ER nonsense and do a medicine residency? Didn't like that guy. He actually told me that pulmonary edema should be treated only in the MICU. Just call his resident and he would treat the patient the right way. Guess Lasix doesn't work in the ER, only the ICU. I did call the medicine resident, but I knew more than he did, and it took him an hour to call back.
Couldn't get the surgery resident to do anything for that guy with the ice pick wound to the chest. He thought the hypotension was vagal. I did a pericardiocentesis when he left and got 50 cc's of non-clotting blood out of his blood pressure went up. The surgery attending did not know how to respond. What's an ER doc anyway? Never heard of such nonsense. But he took the patient to the OR to repair the hole in the heart. Dr. Wagner just smiled. Went off to this meeting in Washington and met about 50 other docs who also taught this ER thing. Maybe they think it'll catch on. Call themselves the American College of Emergency Physicians. Met Ron Crome, John Wangenstein, George Pagroni, Carl Mangold, Harris Graves, Gail Anderson, and Peter Rosen, all smart people. They actually think that they can get board certification. Talking about a real board exam. Fat chance, they gotta be nuts.
1976. Started going to East Lansing, Michigan, of all places, for meetings of the American Board of Emergency Medicine. The test being developed actually asked important stuff. Nice idea, but EM will never fly, especially because the surgeons still hate us. Met Joe Wackerly, who started a residency group called EMRA with me. Probably won't go anywhere. After all, only about 30 residents in the entire country, and I know most of them. We're a weird bunch. 1977. Did some dog studies on endotracheal epinephrine with a guy named Mike Greenberg. It actually works. Surprised nobody had thought of this before. I knew those cardiologists had no clue about life in the ER, but I doubt if the American Heart Association will ever abide this concept.
Started working on this publication called Emergency Medicine News. Met Jairus Hedges, another smart guy. We agreed that no standard textbook helps us in the ER. Those guys just don't get it. Might as well write our own. Maybe concentrate on procedures? Started to read my first EM journal. Can this specialty possibly take off? Worked with Steve Davidson, Brent King, Al Sacchetti. All such smart guys. I need to hit the books to keep up, but no good books out there that actually tell you what to do in an emergency. 1978. Went to the Society for Academic Medicine meeting. Not many docs there. Held it at the Holiday Inn. The internists hold their meetings at the Marriott, and all of them wear nice suits, even to work. Nice try, EM guys. Better luck next time. Some of them seem as nuts as I am.
1979. The ABMS actually voted to accept emergency medicine as the newest specialty. Surgeons still hate us. Too bad, guys. Get with the program. Thanks to Ben Munger et al., I am actually intubating all ER patients now. Still get grief with central lines and chest tubes. Head of the anesthesia left, and we finally got succinylcholine in the ER. Moved to University of New Mexico. Same old hassles. Glad Dennis Price, Dan Tanberg, and George Schwartz are there to give moral support. Might hire this guy, Dave Sklar. Try to get a residency, but no way. Guess 12 residencies in the country are enough. Met Tom Mayer, Ann Honwood, Harvey Melson, Shelley Jacobson, John Glosser. They do the same stuff in other parts of the country.
1983. Heard about Louis Goldfrank in New York. He is a legend in emergency medicine who had a fellowship in toxicology. Sounds like the same problems emergency medicine had to deal with. Think I'll give it a try too. Met Neil Flemmenbaum, another smart guy. Had a moonlighting job in New Jersey where I put in a pacemaker on a patient with an acute MI and heart block, and I was asked to leave by the medical staff by an irate cardiologist who could not be reached to put in the pacemaker. Seems like we should not tolerate waiting for prima donna consultants who do stuff I can easily do myself. Somehow stayed on the medical staff, same problems from an orthopod when I reduced a dislocated shoulder. Hey guys, it's really not that hard. And if you don't own the procedures, I mean, I better get cracking on that procedures book.
1985. Finished Tox Fellowship. Feeling good. Heard that University of Cincinnati has an EM program and needed faculty. Met Richard Levy, Steve Dronin, Jairus Hedges again, that guy's potential, Mel Otten, Bill Barson, all a whole lot smarter than I am. And those residents were awesome, like Mike Spatafora, Leslie Wolf, John Malner, Scott Zvered, Charles Chanovsky, Steve Huff, Brian Zink, Michelle Biros, Brian Gibler, Susan Stone, Sue Ginshaw, Rashmi Kathari, and a bunch more whose names escape me. I think these guys will be famous someday. Was asked to write regularly for emergency medicine news, a way to get something disseminated without waiting 6 months for a journal to respond. Started a column called In Focus, where I get to pontificate. 1986. EMN had the first article in the literature about this weird immune deficiency syndrome, bad infections, Kaposi sarcoma. Probably won't ever announce much. I know I'll never see it in the ER.
Met Louis Ling, Brooks Bach, John Gallagher, Joe Clinton, Mike Tomlangvich, Ernest Ruiz, Mike Callahan, Ellen Taliaferro, Dave Talon, Ken Iserson, Richard Brain, Bob Knopp, Blaine White, Todd Stair, Mark Smith, Bob Hockenberger, Bob Schneider, Dan Danzel, and Kathy Delaney while giving the oral board exam. Getting harder to know everybody in EM, growing fast, some of the best medical students applying. These guys are really smart. I hope they don't make me look bad. The SAEM and the ASEP meetings are getting bigger, no longer held at the Holiday Inns. EMN and Emergency Medicine News writing about smoking cocaine called it crack. That will never catch on, trust me. 1987, asked to resign by the chair of medicine in Cincinnati because I actually gave antibiotics to a septic patient before the medicine resident saw him. What nerve? But they were the correct antibiotics. Still a long way to go. Asked to resign by pulmonary doc because I saw a patient in the ICU with carbon monoxide poisoning and took him to another hospital for a hyperbaric oxygen treatment. More residencies opening up, some getting full department status. Got a call from Rick Bucata. Might give a few talks. Something about EM abstracts. Involved with Jerry Hoffman, Greg Henry, Neil Little, Mike Heller, Jim Ducharme, Peter Versilio, Ron Walls, and clearly smarter than I am, all these guys.
1989. Back to Philadelphia. The residency has grown to 36 residents. Can't possibly get bigger. Most of the old problems solved. Getting almost impossible for me to do nights anymore. Dr. Wagner is still working more shifts than I am. My textbook on procedures is the second edition. Some great contributors who really know their stuff. Starting my own toxicology fellowship, graduating Dave Cohn, Dave Lee, Suzanne Doyen, Chris King, Sue Farrell. 1995. These residents take intubating, chest tubes, central lines, pacemakers, and conscious sedation for granted. They don't realize how hard we work to get them to this point. Must be getting old. Definitely can't do nights anymore. Met a whiz named Billy Mallon. Also, Dan Birnbaumer, Peter Sokolov, Rita Sudoka, John Marks, Jeff Runge. I hear Johns Hopkins, Harvard, and the University of Pennsylvania, Ivy League schools, are actually starting emergency medicine residencies. Who would have thought that this would ever come to pass? Bob McNamara and Howard Bloomstein started the American Academy of Emergency Medicine. They have to be crazy if they can think they can change ASAP.
1998. The ASAP and SAEM meetings sure are getting bigger. So many smart people, very intimidating research. Where do they find the time and energy? Bob Hoffman sure is smart. EM residencies up to 50. And the applicants actually wear suits for interviews, not like the old days. The residents sure are smart these days, a lot smarter than I was. Anthony Dean and Tom Costellatino think that they can do ultrasound at the bedside. Ed Sloan and Andy Jagoda started the Foundation for Education and Research in Neurological Emergencies, another niche for emergency medicine. The year 2000. Wish I could give a talk like Tim Erickson, or knew as much tox related music as Leon Gusseau, or work a PDA phone like Rich Hamilton. Do I really have to learn PowerPoint? I just mastered email.
2001. Lots of new names showing up. Impressive bunch. Rick Bucata, Billy Mallon, and Mel Herbert still whizzes at meetings. These guys are real stars. As are Knox Todd, Ed Newton, Judd Hollander, Sarah Stommer, Kathy Costello, Arjun Chamagam, and Jamier Perron. How are they so productive? Residents now are very competitive. Med students suck up on rotation. I get a good letter from the old fox. Nice homage, but I'm onto them. But they all know PowerPoint and can work a palm. They think EM is a cool specialty. They will never understand what it took to get here. If my mother could only see me now. Now, I really do have an office. My medical school advisor was right. You've got to be a bit nuts to do this ER thing. 2002. Just finished a bedside ultrasound course. Doubt if this procedure will ever be done in the ED, but somehow we got to pass radiology and even convince administration to buy the machines. The residents, of course, take it for granted. Malpractice, crowding, countless meaningless meetings, lack of resources, money issues, no time for reading, research, or teaching. But at least the surgeons, internists, and anesthesiologists are off my back. They actually think we do fine, especially Saturday at 2 a.m.
The medical staff knows how hard this is. Getting less second guessing and criticism, we actually tell them who to admit. They are probably happy to stay in bed and know their patients are being well cared for now that we are actually able to teach their residents. Took a long time. The residents make us look good. Finally realized how hard it is to do full-time emergency medicine when you are older. My medical school advisor is still right. You've got to be a bit crazy to do this ER thing. But I was wrong. It did take off. 2022. Emergency medicine has changed dramatically since 2002. It's now one of the most popular residencies, and emergency physicians are involved in many activities outside of the run-of-the-mill ED patient visit.
I was wrong about cocaine. Crack became tremendously popular and devastating to many who used it. Opioids began to wreak havoc on the population in the 2000s, and the organizations that earlier made pain a vital sign and advocated for aggressive use of opioids now criticize physicians who prescribe them, even for severe pain. Heroin was displaced on the street by fentanyl around 2015, and now it's difficult to find pure heroin. Hospital labs finally started to test for fentanyl around 2020, but many variations are available to drug dealers. I was also wrong about HIV. It is omnipresent and something we see daily in the ED, but new drugs are now effective. Emergency physicians are now involved in buprenorphine treatment for opioid addiction, diagnosing and treating excited delirium, and using ultrasound, now a basic ED technique.
EM education is booming, and the quality of conferences is astonishing, thanks to emergency physicians like Rick Bucata and Mel Herbert. The number of stellar physicians involved in EM education is overwhelming. to name just a few who have impressed me and make me feel totally inadequate: Christopher Carpenter, Eileen Claudius, Stephen Colucciello, David Glasser, Jessica Mason, Ken Milne, Rick Pescator, Jen Schoenberger, Michael Hyun, Maria Raven, Christopher Caldwell, Richard Shea, Peter DeBlue, Michael Winters, Michael Callahan, Corey Slovis, Amal Matute, Todd Thompson, Stuart Swadron, and hundreds more.
The responses to that piece spawned a lot of touching sentiments. We'd like to point out a few. Martha, you just go ahead and kind of pick out the ones you want to do, and you can even direct me to read one here and there too.
Yeah. Before we do that, I had to laugh, and I still laugh every time I hear that piece and when I heard Jim talk about those things that we couldn't imagine not doing today. But a couple shout outs from some of Jim's dear friends. The other thing is, Jim hated to take credit for everything that he did. He was so modest. I mean, this whole piece was just naming people. And I'm so sorry if I pronounced anybody's name incorrectly.
Yeah, me too. I'm sorry about that. I knew I blew at least one or two names.
I mean, some people in this piece I know better than others. Surprising, I was looking at some of the names as I was reading them, and I'm like, gosh, it's been a long time since I've talked to them. But Jim was always just so grateful for his peers, and he always wanted to make sure that they stood out and that they got the credit that they deserved for what they did. He was never full of himself or bragged about really anything he did. Couple of really nice things from some really great people. Dr. Andrew here says, how can I know what I think or what I can do until I've read what Jim Roberts says? Steve Davidson. Jim Roberts was my first senior resident when I was a first year EM resident. He was a fabulous role model. Bob McNamara, you frequently still make me feel inferior. My best to you. A huge legend. And so many more. I wish that we had time to read all of these. But the article is posted on Emergency Medicine News in the June edition of the magazine 2022. If you'd like to go read it. We're going to take a brief pause, Mike, before we read part 2. And we are going to just put up our little pause button while we take a minute to regroup and come back with Jim's article in How to Be a Good EP.
I just want to know how many times he was asked to resign. That was like the funniest thing. Like 7 times, I feel like, during the article, like, I was asked to resign by this guy and this guy. I hope he told him to pound sand, honestly.
Let's just say we're glad he stuck with it. All right. See you after the break.